This is part 2 of chapter 16 on psychotherapy and biomedical therapy. We just want to jump right into the next model of doing therapy, and that is behavioral. One of the key ingredients of most therapies is to have a good, solid, trusting relationship between the person who's seeking help and the provider, basically, the mental health provider. And in a lot of those cognitive behavioral therapies, psychodynamic therapies, humanistic therapies, that is just so pivotal. I would say it's true in behavioral therapy, but a little less so. Behavioral therapy is not so much about trying to gain insight. It's like, here is the behavior that's maladaptive, not functional. And here's we're going to try to figure out what triggers those behaviors, remove those triggers, and bring in new behaviors to replace those. So when they say behavioral therapy, they really focus on therapy, and having all wonderful insight and all that doesn't really matter. It's like, we're here to change behavior. And if you remember the 3 models of learning that we talked about in chapter 6, classical conditioning, operant conditioning, and observational learning, that's what this therapy is based on, that we're going to try to change a person's behavior using these styles of learning. Because I put the dog whisperer here because, I can't remember his name, uses behavioral techniques in working with animals, and they work with humans too. They always have. I think it can be a really powerful form of therapy. I think it can also be really useful with kids because trying to do talk therapy with kids where they're having insight and then trying to understand their unconscious conflicts doesn't quite make sense. It's like, okay, you're wet in the bed every night. How are we going to change that? And they have great techniques for that. Actually, one of the techniques is a classical conditioning technique where they put a moisture sensor underneath the sheets. And as soon as it detects the child wet in the bed, it sets off like a bell or alarm that wakes the child up. And so through classical conditioning, the child starts to associate having a full bladder with waking up. That is classical conditioning used to treat bedwetting, and it works. It's called the bell and pad technique. I didn't even plan to talk about that, but I just think it's brilliant, and it's part of classical conditioning. The behavioral treatments, I already talked about some of this. With classical conditioning, probably one of the biggest things is exposure therapy. I'll talk about that a little bit more detail in just a moment. With operant conditioning, that is often been used in treatment facilities, like psych units in hospitals, where people are given basically like poker chips for doing behaviors that are helpful and good, like brushing your teeth and taking a bath and making your bed and getting dressed on your own. And then they could exchange those tokens for things they want. And so that has been a good operant conditioning device. So use positive reinforcement to encourage good behaviors, and then the patients end up spending more time doing those behaviors that are more functional. Aversive therapy, where the person is punished for unwanted behaviors, that's the least effective that I know of. Your book talks about that in terms of addiction, and there's a medication, I'm blanking on the name of it. Basically, if a person takes this medication, Antabuse, and if they take the Antabuse and then they drink alcohol, they'll just get violently ill and start vomiting everywhere. And they actually have a person do that a couple of times so they get a really good sense like, oh, if I do this, then I'm punished with these horrible symptoms of nausea. But the problem with it is that when people get out on their own then at home, then they just don't take the pills. So that can be a difficult thing for that to work. Observational learning, that's always helpful. There's a lot of times the therapists themselves can model appropriate behavior in terms of self-disclosure, in terms of trusting, in terms of all sorts of things. Also, with some of the behaviors you're looking at, if you have, say, a client coming in, and even with exposure, you have a person who has a phobia of dogs. Part of the exposure can have that patient bring in their best friend, and they can watch their best friend pet a dog and do that. And once you see that, oh, they're not getting bit, then maybe I can do that too. You're using observational learning in that sense. Exposure therapy, sometimes this is done in a single long session. Most of the time it's repeated. So it often goes along with phobias and PTSD, where a person is triggered into panic by certain environmental situations that remind them of a traumatic thing in the past. The goal then is to have a person first, and you may remember this from the chapter on learning, learn to relax. And this is not just where you go to sleep, but where you can bring your heart rate down, your breathing is just regular and deep, and your sympathetic nervous system is not activated. And then slowly have the person approach situations or reminders of situations that in the past have brought them panic and anxiety, and stay in that calm state. If the anxiety starts to get too high, and you have them measure that, like on a scale of 1 to 10, where are you at now? Where are you at now? I'm at a 7. We're going back off. Bring your heart rate back down. And we're going to try this again. So it's exposing, and counter conditioning, basically, so the person can pair the more like calm feelings around the things they originally feared. It's a powerful, powerful intervention. I've been using it with some of my clients who have PTSD, and they have traumatic images that are invasive, that just intrude on their conscious awareness, where I have them walk through and get in the calm state and then tell me all about the trauma that they lived through. And it has actually, based on my clients' self-report, it's getting better and better each time they walk through and tell me the story of the traumatic event they lived through. As you can see, you can click on either one of these videos. They'll show you examples of what it can look like to do exposure therapy using virtual reality. The cognitive behavioral model, often called cognitive behavioral therapy, CBT, is basically self-talk. And so I think every therapist I know will turn to this, because we are, as adults and adolescents, teenagers, constantly we're talking to ourselves. Most of the time, for most people, that's silent inside our heads. But a lot of times the content of that is pretty rough. And so the therapist's job is to identify what those self-statements look like, what that internal dialogue sounds like, and how to catch it, and then challenge it, say, wait a minute, that's not necessarily right, and replace those automatic self-statements with more adaptive and healthy and soothing and comforting statements instead. So the explanations of disorder from the CBT model is the way people, how they get their attention and interpret and use information is distorted. So some examples here include like overgeneralizations. A person can just say, I suck. It's like, that's a blanket statement that doesn't cover every aspect of who you are. And there's some areas where you have strengths, some where you have more weaknesses, but we're all a blend. So making blanket statements like that doesn't help. And then also in a similar way, but that's a little different, it's called polarized thinking or dichotomous thinking, kind of either or. And usually if like I ask you about the classes you have this semester, you're like, I hate that class, or I love that class. And everything's like either really good or really bad. It's like, you know what? Most things are somewhere in the middle. So being able to rate things on a scale of 1 to 10 on almost everything we do can be a lot more valuable than just saying like awful, bad, or great, I love it. I mean, that kind of dichotomous thinking leads to problems. Selective attention, focusing on things that are negative. When I first started teaching, I would get my teaching evaluations back at the end of the semester, and although the majority of them were really good, if I had one negative one that was like calling me out for something, I would hang on to that and remember that and then talk about it with my friend. And it's like, that's called selective attention. We're selectively picking up pieces of information that are negative and using that in unhelpful ways. So those are just 3 examples of distortions in our thinking that cognitive behavioral therapists will try to identify and challenge and replace in how patients think about their own behavior. So we attribute outcomes to certain, or the things we live through to certain events. What they found is if somebody has a bad thing happen and they go make these, what I call the SIG, stable internal global attribution, they're way more likely to be depressed. So if I like wreck my car, I have a fender bender, and I tell myself, this kind of stuff happens all the time. So that would be stable across time. I did that last year. I did have 2 fender benders in the past 2 years. And I said, I do that all the time. And then if we go internal and say it was all my fault and say that there no way could have been any environmental factors or the other person's fault, And then we also globalize that. We go like, oh, I don't want to suck as a driver. I can't do schoolwork. I can't do this. I can't do that. And we just make that one bad event and then make everything else. It's going to make my insurance go up. I now I got to wait for my car to get fixed and just make our whole lives horrible. You're making one event into a stable thing over time where you're totally to blame. There's no other factors you can consider to affect it. And it makes your whole world go bad. Stable, internal, global. It's a recipe for depression. This is a similar example that's described in your book, so I'm just going to leave that there. Aaron Beck was famous for his techniques in CBT, cognitive behavioral therapy, and he's written several books. And his therapy usually involves homework, and you start off the sessions like, did you do the homework? Okay, if you think everybody hates you, the homework for the next week is I want you to introduce yourself to 3 strangers and have at least like a 5-minute conversation with them. Then I want you to record all how that went and bring it back to the next session, and we're going to talk about that. So you're gathering data, you're gathering information, which I think that's really a valuable way. But I lean more towards another form of cognitive behavioral therapy called rational emotive behavioral therapy, REBT, by Albert Ellis. And that is just trying to, again, it's basically identify, challenge, and replace. That's the key to it. Identify irrational thoughts that because most of the attributions we make about things that happen in the world are not based in fact. And so we'll attribute like really horrible things to our own self or to things that they're unrelated to. It's like, is that actually true? And if you can challenge that and then replace it with something better, that's good. Thing about this is when you're doing this kind of approach, self-talk type therapy, self-talk happens all the time. So you may be challenging your own self-talk 30 times in an hour, maybe more. It's a practice and it takes discipline, and you have to keep at it in order for it to work. The last major form of therapy, so it's humanistic therapy. Carl Rogers was primarily the person associated with this, and it went beyond some of the assumptions of the other therapies, which said that in this form of therapy, humanistic, it's like human beings by nature are good, and we have this inborn desire to grow and achieve our potential as human beings, and so a person will grow if they're given the right environmental factors. It basically said that we grow up with getting these conditions of worth that we're basically told by our families that if you do this, you're valued and loved. If you do this, you're bad and you're not. And then we start to have separate conceptions of the self, one who we really are and one who we're supposed to be, or the ideal self. And the more apart those 2 circles are, the more unhealthy we're going to be. The idea is to bring these 2 circles more in conjunction with one another. And Rogers proposed we do it in therapy, basically. And that there are some major conditions for therapy that need to happen in order for a person to feel like their real and ideal selves overlap the most. One is the therapist provides empathy or non-judgmental understanding of the client's experience. And then they provide unconditional positive regard for all of the client's experiences. That does not mean that, a client can say that they have murderous thoughts, and you can say that's human, and that doesn't make you a bad person. It's just something that happens for some human beings. They have murderous thoughts, but that doesn't make you less valuable as a human because you have those thoughts. There's often a kind of a divorce here between sometimes the behavior and the person themselves. And the idea is to value the person themselves, that human beings inherently, just from the get-go, because they're humans, are valuable. The other thing that's really important in humanistic therapy is to be genuine. The therapist has to be as transparent as possible. And so this makes humanistic therapy look different for every therapist, because every therapist has an independent personality. So when you see me completely transparent, that's going to look different from somebody else being completely transparent. And so you be honest day by hour who you are in that moment. And you're genuine, you're in the moment, and you're present, you're fully with the person trying to understand their experience. When done correctly, it's incredibly powerful. Which therapy is the best? So when you look at the research, they all end up about the same. So we went through psychodynamic, cognitive behavioral, and humanistic. There are more forms of therapy too. There are some that are particularly better for others. I mean, exposure therapy is great for phobias, panic, and PTSD. Meditation is good for anxiety. I have a few other things here too. I'm just aware of the time, so I want to keep moving. I told you about the biomedical therapies I'd like you to read about in the book. I will ask you test questions about common names, what types of medications are there, what they're used to treat, and what their side effects are. And sometimes what neurotransmitters they operate on. The different forms of therapy. You can do one-on-one with a therapy and a client. You can do group therapy, which I'm going to say more about in just a second. Couples therapy can be really good. I love couples therapy, but it's almost like a small group. Family therapy, that's its own tradition. And a lot of times you will have a counselor or therapist basically realize it's a family system that's really kind of gotten off track. And so a lot of times, and I have a peer addiction therapy too, that basically, I mean, if you have a family therapist who's coming in with a family that has a person who's addicted to substances, I mean, that therapist is going to ask who in this family benefits from this person being addicted to substances and tries to figure out how the patterns of reinforcement happen within a family. Read about the addiction therapy in your book. I'm not going to say much more about it right now. Group therapy, I don't conduct it because I need more space than I have in my office. But there's a lot that can come from that, because when you're one-on-one, you're a client and you're working with your therapist, and your therapist gives you feedback and like, hey, you're coming at me with this all the time. If you hear from the therapist, it's possible to dismiss that and say, that's one person's opinion. If you have 8 people in a group who are all your peers and they're saying, yeah, you come off as hostile. Yeah, you come off as hostile. Yeah, you come off as hostile. It's kind of difficult to discount 8 people like that. And so getting group feedback can be really powerful. Like, I mean, then you could ask for more information. How do I cover? What do you see as hostile in what I say? And then you can get behavioral comments. You can also have observational learning. You can realize it's okay to trust other people. You can see that someone in the group self-discloses and they get support, and you're like, oh, I didn't know that's possible. I guess I can do that too. And then you could experiment and try that yourself. There's a lot of value in group therapy. Also realizing that you're not alone with a lot of the problems you work with, especially if you do specific type groups. They have all sorts of groups dealing with phobias, eating disorders, addiction, you name it. There are some barriers to therapy. I put this big stone as roadblock. Cost, it's expensive. Is it available online? Is it in the community? Actually, with COVID, I'm now seeing all my clients online, so it does make easier access geographically to help with clients. Also, most insurance now is waiving the copay for therapy because of COVID. Also, a lot of people want similarity in terms of who they're working with as therapists. If you're white, do you want a white therapist? If you're black, do you want a black therapist? Does that matter to you? Do you want someone, if you're young, to be an older therapist? Is it okay if you're older and the therapist is younger? Do you want them to have the same religion? The similarity factors are important. What's it going to take for a client to trust? And that's only a question each individual client can answer for themselves. Yeah, and I mean that's a powerful piece of therapy, because if you can't have the trust from the beginning, it's going to be difficult for that therapy to be effective. Sometimes another barrier to think is the therapy stigma. Just the idea that you don't tell other people your business or your family's business, that having problems perceived as weakness just keeps a lot of people away from therapy. Also, we know there's a history of healthcare systems mistreating minorities. I mean, you go back to the Tuskegee experiments that I talk about in my intro psych class. I mean, you go back to, yeah, there's a full history of that happening. And then language barriers can be a factor too. For instance, I don't speak Spanish, and I've not had a Latino speaking person request therapy with me. But like I would say with most therapies, I mean, like a good barber or hairstylist, I mean, you find out through word of mouth who's good, who you can trust, who's effective. Then you go with people you trust and who they've worked with. That seems to be like a good avenue for success. I've made this recording almost 20 minutes, so it's a little longer than I intended. I hope this has helped, and that's it.